Good morning. First, at the outset, I would like to thank our Indian Arthroscopic for starting a nice online education initiative. And I would like to thank our President, Dr. I.P.S. Oberoi, and Dr. Sonanda Samantha, our Secretary, and all our governing council members for arranging this program. I've been given a topic of how to demonstrate arthroscopic Bankart repair. I'm going to demonstrate a live surgery of arthroscopic Bankart repair in a patient who has got a ALPSA type of lesion. So this gentleman is a 26-year-old male who has fallen down while playing 2 years ago, and his shoulder got reduced nearby at the time, but had 8 lesions since then. His movement is restricted due to pain, but he has got passive, he has got full movement. After 80 degrees of passive abduction, he feels very uncomfortable, indicating he has got a feeling of dislocation. And this feature here, in the MRI, the axial cut shows the evidence of ALPSA type of lesion. And clinical examination reveals he has apprehension test positive, where abduction external rotation brings pain for him. And relocation test by pushing the humerus back posteriorly relieves the pain. In the meantime, if we try to external further and release the pushing humerus, he gets severe pain. That is surprise test. So that is his clinical situation. Now we are going to go into the operating video to show how this patient's Bankart repair has been dealt with. So now we have the arthroscopy picture now. The camera is put from the scope is put from the posterior portal. What you are seeing is a rotatory interval. Subscapularis tendon is seen over there. First thing is to make an anterior portal. To make an anterior portal, I want to make the ideal location, which is just above the subscap tendon. With a needle, try to make sure you are able to reach the point of interest, which is the anterior inferior part of labrum. And with a 11 blade knife, make a small incision just parallel to that needle. And then job is to introduce a cannula over there. For introducing a cannula, put a Wisinger rod first. And through the Wisinger rod, introduce a introducing stick. And then 8 mm cannula goes in over there. So next is I want to make another portal just below the biceps tendon. So put a needle over there and then introduce a Wisinger rod. So you are ready for viewing your portal from the anterior side. Now I'm going to come out of the posterior portal from the scope. I'm going to put my scope into the anterior portal so that we can have an end-on view of the glenoid and humerus. Now the scope is gone to the anterior portal. Now we are able to see the posterior capsule now. In the posterior capsule, we have got a Wisinger rod and there is a posterior portal through which I'm going to put a 6 mm cannula. So for putting a 6 mm cannula, I'm putting the introducer now. And once the introducer is gone through the capsule, then you will see the 6 mm cannula coming out. When you're putting the cannula in, make sure you have at least 2 ribs of the cannula well inside so that it is well secure. Next job is to go and focus on the anterior part of the glenoid. So as you are seeing the anterior part of glenoid now, the glenoid labrum is pushed back quite medially, and this is a typical ALPSA type of lesion where your labrum will be far medial than the glenoid margin. The first job is to take that glenoid labrum out of the bone. So in order to do this, I'm using something called liberator, or you can use anything like periosteal lever type of device to peel off the labrum from the bone margin. So gently peel it from distal end and then slowly come out to the proximal end. In other words, come from 5 o'clock position or 6 o'clock position and then follow it up to the 3 o'clock or 2 o'clock position. And once you release it, you make sure you are able to see the subscap muscle underneath, which you can see subscap muscle is seen over there. And make sure you release right down to the edge of the inferior most end. So once you have got that, you see that labrum is lifted off and flowing up to the glenoid bone margin. That is a typical appearance after liberation of the glenoid labrum. Next is I want biological healing. So for having biological healing, we need to freshen the bone margins. So to freshen the bone margin, what I am using here is a shaver blade. When using shaver blade, make sure the shaver blade is facing towards the bone and not towards the capsule. Because if you to face towards the capsule, we can damage the capsule or labrum quite badly. So make sure you freshen the bone margin right from 5 or 6 o'clock position to 3 or 2 o'clock position, slowly and gradually, so that you have a nice freshened bone area over there. Next part is to have a stitch through the capsule. For this, I am introducing a antegrade suture passer and take capsule for about almost 1 to 1.2 centimeter down from the labral margin into the capsule and take a bite of the suture material. And this bite should be taken at about 5:30 position or even 6 o'clock position, so that when you put it back to the glenoid bone margin, you have nice capsular shift. So now we have got the hold of a nice chunk of capsulolabral tissue. Next job is to make a drill hole for introducing your anchor. So making a drill hole is at about 5 or 5:30 position, and pre-drill for placing the Nautilus anchor by using a drill sleeve. While using a drill sleeve, gently tap the sleeve so that it is well secured onto the bone. Drilling through the bone and make a pilot hole for inserting a Nautilus anchor. So once you have done that, make sure you have a bony margin between the medial aspect of the glenoid and also the pre-drilled hole, so that you have at least 1 millimeter of bony margin. Otherwise, you can skew up the anchor and it will have ill secure fixation then. So now we have got this. Now I'm introducing the Nautilus anchor, where through the eye of the Nautilus anchor, I've threaded this suture material and I'm going to put it back into that pre-drilled hole. So now the Nautilus anchor has come into place. I'm gently going to tap it into that hole. While you are tapping it in, you are going to at least tighten the capsule, that is anterior inferior capsule, by doing an inferior shift and also anterior capsular tightening. And you can read almost 1 centimeter of the tissue can be chunked in, so that you have nice tension over the anterior inferior capsule. This is a very essential step of the whole surgery. This step actually brings down the head of the humerus to the center of the glenoid. Now, residual suture material can be taken off by cutting the residual suture plus to the Nautilus anchor. So first suture has been taken. Now we are going to take the second suture. Second suture is going to be taken from about 4:30 position. So 4 or 4:30 position. So I'm using the antegrade passer to take capsular tissue. Almost 1 centimeter of tissue has been taken, and taking with the suture material and hold the suture material area of capsulolabral tissue. So we have this capsulolabral tissue nicely taken. Now the job is to make another drill hole. This drill hole is going to be made at around 3:30 or 4 o'clock position. Again, the same principle. Tap the drill sleeve so that you are well secure, and then make the drill through the drill sleeve to make a pilot hole. So I am drilling it now to make a pilot hole, and once the pilot hole is done, it's important to have some bleeding, which will help for some biological healing also. So don't worry about that kind of bleeding which happens there, which will help only for biological healing. So now again, the same principle what I did earlier, that is a second anchor. When you are doing this, again, make sure you tighten that capsule, anterior capsule, so that you are maintaining the tension, bringing the tension gradually from inferior to superior. So take the residual suture material out by cutting it flush to the anchor. The next step is to take another bite of the capsule around almost 2:30 or 3 o'clock position, or almost at the level of the subscapularis tendon area. So for this, I am using a lasso type of suture passer. It's a 30-degree angle suture passer, where I can take a chunky tissue of capsule labrum and retrieve it through the inside margin of the capsule, and one nitinol loop is brought in. This nitinol loop can be actually brought out through the posterior cannula. That is a working portal cannula, and with that we can actually, through the railroad technique, we can retrieve a suture material, which is another fiber wire is going to come from the posterior portal to the anterior portal. So now we have another chunky tissue of capsular labrum around 2:30 or 3 o'clock position, which can be kept over the anterior cannula. It is actually very difficult to do drilling and applying not through the anterior portal, because when you are coming at about 2 o'clock position, you have very little space to work on. So I have switched my scope to the posterior portal, and I am seeing the joint from the posterior portal and drilling a hole around about 2:30 or 2 o'clock position. So I'm drilling a hole and making a pilot hole, and then the plan is to feed that suture material through the Nautilus anchor and get it back into that place, so that you have one more layer of suturing back, and so that you have nice tightening of the anterior capsule right from 2 o'clock position to up to about 6 o'clock position. That's where the pathology lies on. So now the third Nautilus anchor is going in, and while the anchor goes in, make sure you gently tap it, and so that that anterior capsule forms a nice hammock effect over the anterior tending side. So this is the completion of the third anchor, and the residual suture material has been cut off now. Now we can see that there is a nice anterior capsule which is heaped up nicely. I'm going to put the scope from the anterior end also now in a minute to show how it's looking from the anterior portal. Here you have a nice heaped up tissue where you have that nice bumper effect. Now the camera is going to the anterior portal. You can see the humerus and the glenoid, which is the humerus is well centered on the glenoid, which is a very important part of the surgery. It's tensioning the humeral head right down to the glenoid in the center. So I would call this as a anterior stabilization procedure or even a tensioning procedure to restore the humerus head to the center of the glenoid. But that's nearly the end of the procedure. And with this, our rehab protocol for these patients is keep on arm swing for about 6 weeks, do pendulum swinging movements. You can start it as soon as possible. And that's the only movement I allow for up to about 4 to 6 weeks. You can start doing abduction up to 90 degree from 6 weeks to 10 weeks. And external rotation is the only movement which has to be avoided for at least about 10 weeks period. That is the only one which can produce tension on the stitch. So abduction, external rotation, that is the above movement should be avoided for at least 10 weeks. Allow for full range of movement in about 14 weeks time. You can do strengthening exercise from 14 weeks to almost up to 9 months. And if the person wants to play sports, usually they can allow to do sports after 9 months. So this is a picture of the same patient who is 4 months post-op, who is demonstrating almost full range of movement after the surgery. So this is the end of the demonstration of arthroscopic Bankart repair. I would like to thank Indian Arthro Society for giving this opportunity. Thank you very much.